This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life, are you getting enough sleep? This woman snored for years but had no idea how bad her condition was.
When I would wake up, I still felt tired.
Her diagnosis and the device that changed everything. Plus, our panel of experts on what you need to know to get a good night's rest as Health Matters goes in search of sleep solutions. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
Good evening, I'm Teresa Lukens. Tonight, a topic that might not sound health-related, and that's sleep. But those who study it know that there can be some very serious consequences to sleep disorders. We're going to tackle that and explore solutions to help you get a better night's sleep. Leading our discussion tonight is our panel of experts, and here they are. LeAnne Harvey is a registered respiratory therapist as well as a registered sleep technician. She works at the Providence Holy Family Hospital Sleep Center in Spokane. Devon Grant is a postdoctoral research associate at the Sleep and Performance Research Center at Washington State University in Spokane. She holds a master's degree in clinical psychology and is a licensed mental health counselor specializing in cognitive behavioral therapy for patients with insomnia. And finally, Dr. Richard Simon Jr. is the medical director at the Kathryn Severyns Dement Sleep Disorders Center located at the Providence St. Mary Medical Center in Walla Walla. And welcome to all of you. I look forward to a great discussion tonight on sleep. And we welcome your questions tonight. You can email us or call us anytime with your questions. And Dr. Simon, I want to start with you on this topic of sleep. Why is it so important for us to get a good night's sleep as it relates to our overall health?
Well, sleep is the most important thing in overall health. In fact, one could argue that being awake, we're awake so that we can build a house, we can eat, we can do things like this so that we can sleep at night. So maybe the question is, why are we awake? Sleep is the natural state for life. Mm-hmm. But when we sleep well, we feel alert, energetic, refreshed in the daytime, optimistic. We remember things, we learn things, we don't forget things, we have coordination, we react to the environment, we process multiple different things at the same time, and we do it accurately. Without sleep, we get depressed, we get moody, we don't remember things, we don't process things, we pay attention to things, perseverate, we sometimes call it, that aren't too important, we repeat it over and over again unsuccessfully, we don't solve problems. And poor sleep also causes immune dysfunction, so we don't fight infections well. It can lead to cardiovascular complications, it can lead to diabetes, obesity. Sleep really is one of the most important pillars of life.
Mm-hmm. And we have been studying sleep a lot more recently, Devon, and learning a lot more about those connections. Talk about your work as it relates to sleep and our overall health.
So down at WHU Spokane, we've been studying essentially sleep, from the dish in a cell form all the way up through humans. And so what we specifically look at is what happens when we take healthy, normal sleepers and we put them on simulated shift work schedules or sleep deprive them, and then see what happens to things like decision making, emotion regulation. And as you can imagine, all of these things go downhill very quickly. But people are very bad gauges of this. So they may think that they're doing really well on a task, but their performance is telling us a completely different story. So there's a discrepancy between how people actually perform and how they're potentially driving down the street.
Have we, in recent years, has this become more of an issue because of technology, because of different work schedules and that sort of thing? It doesn't seem like this was an issue 50 years ago. as much.
Yeah, it probably was, but I think, you know, there's a lot more things that we engage in during the day. So we all have technology that we are tuned into, and we know there's been lots of research out there that has shown that people who are on their screens close to bedtime, that is impacting your sleep later at night. So it's making it more difficult for you to fall asleep. And, you know, there's more people that engage in shift work. And, you know, it's kind of a necessary evil in our society. We have a 24/7 society. We are going to have people that work at night. But I think what we're also seeing is that we're now able to look at how, you know, what the effects are 20 years down the line of somebody doing a shift work type schedule. And what we see is kind of like you've mentioned, is that there's all these health consequences of engaging in irregular shift work.
Mm-hmm. And so clinics like yours, LeAnne, have become very popular. People want to know more about why they're not sleeping well. When do you end up seeing them?
Well, we see the patient when they have discussed their sleep problems, their sleep issues with their primary care physician. They get referred to a sleep specialist, usually a physician that's board certified in sleep. And then they're referred to our lab, and they come in for either a overnight study, sometimes a daytime study if the physician suspects other sleep disorders, and sometimes for just a take-home sleep test. But we see the patient when their physicians have recommended that they do something about their sleep. Or
typically, what are some of their complaints? What are they saying is happening that they finally end up coming to the clinic?
Their bed partner complains of them snoring, or they stop breathing. Women usually more vigilant about their partner's sleep than vice versa. But they're getting better. They are tired during the day. They wake up feeling like they've been drugged behind a truck. They have headaches, dry mouth. They fall asleep at work or in class. Yeah.
Any number of issues.
Any
like
number
that,
of issues.
like
Yeah, those
that.
are the biggest complaints. Probably is excessive daytime sleepiness and their partner's complaints of snoring and witnessed apnea. We call it, where the bed partner witnesses the person stop breathing during the night, snorting awake.
And we've actually come up with a lot of treatments. There are some things that people can do once they find out they have an issue. What are some of those things?
Well, when we fall asleep at night, one of the first things that happens is we start blocking sensory input, so the brain stops paying attention to your external and internal environment. And the next thing that happens as you go into non-dream sleep is your skeletal muscles relax. When we go into dream sleep, our brain is so active that the brain actually paralyzes us, so that the skeletal muscles are completely paralyzed. Well, the tongue and the back of the throat are skeletal muscles. So when we fall asleep at night, the muscles to the back of the throat in everybody are going to relax and they're going to collapse. And in some of us, 25% of men and about 10% women, the back of the tongue can fall over the breathing tube, the trachea, blocking the flow of air. The muscle that controls breathing that does not relax will start sucking harder to get air into this narrowed passageway. As the airflow gets funneled through that narrowed passageway, the airflow gets turbulent. As the airflow gets turbulent, these tissues start to vibrate.
That's where snoring comes.
That is the death rattle. That is not something that is normal. It is frequent and it is common, but it indicates the only way you can snore is if you are suffocating. Mm-hmm. So when that happens, you start sucking hard to get air in. When you do that, you can suck blood up from the legs up into the right atrium, so the right side of the heart fills up with more blood than it's used to, like you're fluid overloaded. When that happens, it'll secrete a chemical that goes to the kidneys, causing you to get up to pee. So getting up at night to urinate many times is usually secondary to sleep apnea, not diabetes or drinking too much water at night. The mouth comes open, so you start awakening with a dry mouth. As you jerk awake, you pull the muscles in your neck, and so you start awaking with headaches. The blood pressure falls when you're choking like this. The oxygen level may fall. When you wake up, the blood pressure shoots up. The oxygen level shoots up. This goes on all night long. That activates the sympathetic, parasympathetic nervous system, so we get inflammatory responses, which increases the risk of heart attacks, strokes, and the brain is constantly waking itself up all night long. and you're moving about to keep you breathing at night. So you get a very fragmented sleep. So now you wake up exhausted, you start developing high blood pressure, the risk of heart attacks increases, obesity increases, diabetes, everything. Fortunately, it's very easy to treat. We put this little mask over your nose. It's hooked up to a hose that goes to a little tiny machine that just blows a back pressure of air.
It's a CPAP.
A CPAP stands for Continuous Positive Airway Pressure, CPAP. Just blows a back pressure of air to the back of the throat. So when the throat starts to relax, it hits that higher column of air. Bingo, it's gone.
Mm-hmm. Well, I want to get back to that too, because that's a perfect place for us to talk about how most people do complain about sleep disorders from time to time. But how do you know if you really have something more serious? And one way to tell is to go to one of the sleep labs, but that's not the only way. And LeAnne mentioned it. There's actually a take-home test that you can use, and we talked to a woman who used this simple test.
This is Mary Conley doing the things she loves, getting outdoors, traveling, and spending time with her grandkids. But it hasn't always been like this.
I have always snored that I remember, and it was getting louder, and I was always tired.
So tired, in fact, that she had trouble staying awake during the 15-minute drive home from work. As she got older, it got worse.
I remember not feeling rested in the mornings when I would wake up after a night's sleep. I still felt tired, and I was tired during the day. I just thought I was aging, and you get older, you get more tired.
It wasn't until she went in for a simple sedated procedure that she learned just how bad it was.
They said I had stopped breathing several times, so they suggested that I get an evaluation for sleep apnea.
Mary came here to the Providence Holy Family Hospital Sleep Center, where she was given a take-home test.
It's a little box you hook up, and it measures your heart rate and your breathing, your oxygen levels. It was easy. Just one night.
The test results confirmed that she suffered from sleep apnea, and Mary was given a CPAP machine just like this one.
I took it home and started wearing it and noticed a huge difference.
Mary says it took her about a week to get used to it.
And after that, I just noticed I was more rested in the morning. I had more energy.
The diagnosis and treatment changed her life.
I started working out, getting just healthier because I had the energy to get out and move.
Not everyone who comes to the sleep center is given a take-home test. Some people are observed overnight. Sleep technicians like Denise Simmons are able to determine what kind of sleep a patient is getting using about 30 different sensors and video.
We look at snoring, teeth grinding, heart rate, oxygen level, the rise and fall of their chest and abdomen, and muscle tone, like maybe they have leg jerks.
And much more. In just one night, the Sleep Center compiles hundreds of pages of data.
We do get a really good information, and the doctor does get a really good report.
Whether it's an in-home test or a night here, it's testing that is making a difference.
It's awesome that something that's not invasive can have such an impact on people's lives.
It just feels better to get good sleep.
So, LeAnne, what is the difference between the symptoms that she had and being able to do the take-home test compared to people that come spend a night at the clinic?
Well, the take-home test consists of a little unit that kind of ends up right here that has a effort belt that measures the muscle effort when you're breathing. There's an oximeter that checks your oxygen level and your heart rate that you wear on your finger. There's a cannula, much like an oxygen cannula, but there's no oxygen coming through it, that just with short prongs that fit in your nose. And you take that home. You're instructed by the technician during the day on how to put that on, and then the patient takes it home and puts it all on and goes to sleep.
And the box
just turns the box on.
Registers all that information.
Yes, and then when they wake up in the morning, they turn it off and they bring it back and we download the information and send a report to the physician. When they come in for an in-lab study at night, they come in, the tech meets them, shows them around their room. They don't sleep, at least in my lab, in a hospital bed at all. They sleep in a full-size bed. There's TVs in the room. It's just like a hotel room.
Well, people think it's a little more clinical than that, don't they?
Yeah, but it's really not. Of course, there's a camera and a microphone in the ceiling, but otherwise you'd think you were at a Holiday Inn or something. There's bathrooms and,
Would you be having more severe symptoms to do the clinic study?
Well, not necessarily. A lot of it now depends on your insurance and whether the insurance wants to pay for a in-lab study or whether they pay for a home sleep test.
Essentially, they'll show the same thing?
Essentially, yes. With an in-lab study, we use electroencephalogram leads on the head, 9 of them, and that tells us whether the patient is awake or asleep by showing their brain waves. We can also, one thing that a home sleep test doesn't cover is we put leg leads on the shins, and those pick up leg jerks, like if a patient has complaints of restlessness in their legs at night, and that is a sleep disorder if it's happening and waking your brain up. So other than that, it's really pretty much.
Does it take more than one night?
For an in-lab study? No.
Do people stay more than one night?
Just one night. They come in about 7:30 in the evening, and they're usually ready to go by 6:30 or 7 in the morning.
Okay. We have our first email from Allie, who says, other than the CPAP machine, what other ways are there to treat sleep apnea? Who would like to tackle that? Devon, do you have some response to that?
From my experience, it depends on the severity. CPAP may be the best thing that's out there, especially if you have a really severe sleep apnea. There is some positional therapy that you can do if you have, more minor sleep apnea where you make sure that you're on your side and not laying on your back. That's when, apnea is more likely to occur. But at the end of the day, if you are reaching a certain threshold, CPAP is really kind of the best thing that's out there.
Mm-hmm. Because there's advertised pillows, there's gadgets.
Can help too. Alcohol tends to make apnea worse. So the conservative things would be try not to drink before you go to bed. Cigarette smoking tends to make it worse, so try not to smoke. Being obese makes it bad, so if you can lose weight, that can be helpful. Non-supine sleeping on your side. There are also dental devices for mild apnea that work pretty well. They pull the jaw forward. The back of the throat still collapses, but by pulling the jaw forward while you're sleeping a little bit, you've got more room to collapse.
Mm-hmm. Is that something you talk to a doctor or a dentist about?
We have 2 board-certified dentists in Walla by the American Academy of Dental Sleep Medicine that we use. So I don't make those dental devices. We have a dentist who's trained in it do it. There are a variety of surgeries that can be done for apnea, but they're not horribly effective unless you do really big league surgery, and even that, if you move the whole face forward, it only is about a 40 to 60% cure rate. And about 2 or 3 years ago, a new device was approved by the FDA that you implant. You run a wire up the neck, and it will actually stimulate the nerve going to the tongue so that the tongue doesn't relax. We have no experience with that in Walla, very little experience in Seattle, so I don't know how that's going to work out. But there are other treatments. Although CPAP, if you can tolerate it, and the new machines are much smaller than what you showed, much more comfortable, it will get rid of apnea in over 95% of patients as long as you wear it.
Mm-hmm. And it does take some time to get used to.
It takes a while, 4 to 6 weeks.
You have to build up that tolerance to it.
Some people take to it immediately. But I remember when I started my CPAP, it took several months to get used to it, although the weird thing was I felt great right away. That's the strange thing.
Yeah. Very good. Well, you have another email, this one from Nicole. My mother always said it was the hours before midnight that mattered most when it came to quality sleep. Is there any truth to that?
I would say yes and no. It depends. Some people are, more morning people. Some people are more night owls. If you're more of a lark, as we would say, then yes, maybe those early hours of sleep before midnight are important. But if you're more of a night owl and your body doesn't actually want to go to sleep until 1 or 2 in the morning, no, it doesn't matter. It doesn't matter going to bed before midnight. It's really just getting, our gold standard is 7 to 8 hours of sleep in a 24-hour period is really what the benchmark that everybody should be striving for.
Mm-hmm. Are men and women different in regards to sleep? It always seems like my husband needs less sleep than I do. But do we basically, as human beings, as you mentioned, need 7 to 8 hours of sleep?
Yes. I mean, there's some people out there that we would categorize as short sleepers that maybe need 6 or fewer hours a night. But that's a very minimal amount of people. Most people, the vast majority of people, need 7 to 8 hours. And, you know, there's still kind of a, people kind of pride themselves or boast about, you know, not needing that much sleep. And the reality is they do. We all need about 7 to 8 hours of sleep.
They're fooling themselves.
Yes.
All right. We have our first phone call. Tom in Spokane. Hi, Tom.
Hi. Thanks for taking my call.
Absolutely.
I've had a CPAP for probably about 7 or 8 years, and I still, and I've told my doctor about this several times, I still wake up tired. And his suggestion was, well, when you get up, drink coffee. It helps a little bit, but it still concerns me that when I sleep, even if it's 7 or 8 hours, I wake up feeling tired.
Do you have a regular sleep routine, Tom?
Well, I'm one of those night owls. So I guess, you know, in a sense, yes, but I'm not, you know, I would like to try to get to bed earlier, but I'm awake. I don't feel tired until, you know, 1 or 2 in the morning.
Right. Any advice for Tom?
Well, it could be that he's not on the right pressure setting on his CPAP machine. CPAP or sleep apnea, unfortunately, doesn't get better as we get older. It gets worse because we gain weight and our muscles and our tissues get floppier and weaker, and it's just a fact of life. But Dr. Simon, what do you recommend for how often a person gets a sleep study?
We generally do one diagnostic, and then, frankly, we hardly ever do another one after that. Tom, are you on an automatic adjusting CPAP machine?
I don't think we still have Tom, yeah.
Well, the question's for somebody who's a night owl. Is what you're getting at, is if he really is a night owl. There's nothing wrong with that, by the way. Our brain, everybody's brain is set to go to bed and wake up differently, and it's hard to change that. It can be changed, but it's hard to do it. So if he's really a night owl, like going to bed at 1 or 2 in the morning, that's when his brain will have him fall asleep. He can go to bed at 10 o'clock at night, put the CPAP on, and he will lie tossing and turning. And if he's going to get up at 6 or 7 in the morning, for example, then he's going to be sleep deprived because he's basically a night owl and not getting enough sleep. So one of the questions would be, well, if you're going to bed at 1 or 2, are you sleeping until 9 or 10? And if the answer is yes, and you're wearing your CPAP and it's properly adjusted and you're still tired, there are a cohort of patients with sleep apnea. We don't understand why, but the excessive sleepiness does not go away. Now, my experience has been these people typically have had fairly severe apnea with low oxygen levels, and there's some animal models to support why that would be. But most of us are using automatic adjusting CPAP machines right now, so we'll set a pressure range so the pressures can change as a person sleeps. But that gets at your question, is in the old days, we didn't have these machines. And so the first thing we would ask, if they're getting 7 or 8 hours of sleep a night, wearing their CPAP every night and still sleepy, is the apnea really controlled? The new machines actually will monitor breathing breath by breath so we can actually get an assessment. And if it is well controlled, if they are getting 7 to 8, 9 hours of sleep a night and they're still sleepy, then there's further work that should be done probably.
All right, very good. Joan in Calgary. Hi, Joan.
Hi.
Do you have a question?
I do. My husband has been diagnosed with sleep apnea. He has a mild case of obstructive sleep apnea, but he has a fairly major case of central. And I would be interested in hearing your input on what is central sleep apnea and how it can be treated. He has been using a CPAP machine. He doesn't notice any difference. He's still having up to 40 episodes a night. So we're kind of wondering where to go from here.
Joan, can I ask you a question?
Uh-huh.
Does he have any heart disease?
He has been checked out by a cardiologist, and he has none.
Oh. And can I ask another question? Is he on any narcotic pain medications?
None at all. Okay. No, he's actually on no medication at all of any kind.
All right. Joan, thank you for your question. Anything, Dr. Simon, for Joan?
Well, central apnea, is, I was wondering if somebody was going to ask about this. That's a real difficult situation. So what determines when we breathe in the daytime is carbon dioxide levels. When they rise, we breathe faster. When they fall, we breathe slower. But also in the daytime, we have central apneas all the time. Right now, you have a central apnea as you're waiting to respond and tell me to stop talking or something. So we'll take a breath in and hold it. That's a central apnea.
Okay.
When we fall asleep at night, we lose that cortical influence, and so we're run just by the ventromedullary brainstem areas. And so as the CO2 rises, we speed up our breathing. As the CO2 drops, or the opposite way, I should say. No, speed it up when it goes up, and we'd slow down our breathing when the CO2 drops. And normally it's regulated very carefully. Something happens in central apnea, such that the gain on this whole system increases, so that the brain, when the CO2 rises, over-responds and can breathe too fast. And when the CO2 then gets too low, it'll stop breathing. That's called Cheyne-Stokes. That's a periodic type breathing, often seen in patients with heart disease. That can be treated with CPAP, although usually CPAP doesn't work.
She mentioned he was having 40 episodes a night.
So we use anymore something called an autoservo ventilator, a non-invasive one. So this actually will breathe for the patient when they stop breathing. The reason we ask about heart failure, though, is these autoservo ventilators in patients with bad heart failure actually make life worse. And so central apnea, there was a big study published 2 years ago that ASV therapy for Cheyne-Stokes respirations with bad heart failure actually may increase the risk of early mortality.
So he should talk further with his doctor.
He needs to go back and see his sleep specialist, right? And
okay.
Narcotics and opioids, we're in the middle of an opioid epidemic right now, as we've been hearing about. And I think that the mechanism of death is actually central apnea, because the opioids greatly inhibit the ability to breathe once you're asleep.
Okay. We have Fran from Calgary. Hi, Fran.
Hi, thanks for taking my call.
Absolutely. Thank you for waiting.
Yeah, it's okay. Learning a lot this time. Years ago, I did a couple of sleep studies, and when you have fibromyalgia, they found that alpha waves interrupt your delta waves, and that can interrupt your sleep. And do you have any suggestions as to how to proceed, how to get a good night's sleep?
Explain what Fran is talking about, Devon.
So we have all different sorts of brain waves throughout the day. So right now I have kind of alpha waves, meaning I'm engaged in something. And so when we sleep, our sleep waves slow down, then they get a lot bigger, and we call that delta waves. And so a lot of times for people that have chronic pain like fibromyalgia, what they see is a sleep wave, so kind of a big delta wave, but superimposed over the top of that is an awake wave called an alpha wave. So that is very tricky. And a lot of times, I believe, is there a medication? Can they treat that with medication? No.
Not easily.
Okay.
It's the way I've always thought of it, but she's the expert in this, I think, because that's the type of research they do. Is it sort of like part of the brain is awake while part of the brain is asleep? And they're even faster frequencies,
so they're
beta waves.
Fighting each other.
Yeah.
Sort of, yeah. There are lots of places where the difference between being awake and being asleep isn't as clear-cut as we would like. Yeah. Sleepwalking, acting out dreams at night, and this alpha-delta sleep that she's talking about in patients with chronic pain. It's a difficult issue.
One of the things that we did find when I work with insomniacs who chronically come in with fibromyalgia or other chronic pain disorders is that we start to look at, kind of relaxation components, mindfulness, meditation, deep breathing, just to try to kind of reduce that arousal level that people can build up throughout the day. And that can actually be really helpful. It takes practice, takes time, like everything. But I think that might be a good thing to look into, is just trying to, throughout the day, lower that arousal level through mindfulness again, breathing techniques, just to try to kind of eliminate that. So when she tries to go to bed at night, she's actually ready to go to bed and her brain isn't fighting her.
Which is actually fairly good advice for everybody. We don't have good sleep hygiene. We just don't. We've messed with it too much, and we need to get back on track. Is that right, LeAnne?
We do, and we might start with our children, our teenagers, teaching them good sleep hygiene. You know, turn off the laptops or the iPads at least an hour before you go to sleep at night. Don't sleep with your cell phone in your hand. You don't need to text your friends at school in the middle of the night. Caffeine, you know, stop the caffeine at, 4 to 6 o'clock in the afternoon or in the evening.
Is eating right before bed a bad thing too?
It can be.
Yeah.
It's, a small snack, is usually all right. Warm showers, warm baths, those are great for relaxing you at night. If you can't sleep at night and you need to get out of bed, don't turn the TV on, don't turn the computer on. Just read a book. Mm-hmm. Don't turn the lights on bright.
It can be so difficult to just shut off your brain. In fact, I can find that I'm very, very sleepy, I'm ready to go to bed, and the minute my head hits the pillow, I start doing a shopping list and what I need to do the next day. And what's some good advice for just shutting down?
So what I tell patients to do, which very few do, but you can do an experiment on yourself. So if you have trouble shutting it down, what you do is take a 2-week vacation. Go to bed whenever you want. Wake up whenever you want. Don't use an alarm clock. Don't use a bedtime. And get an idea for when you normally would fall asleep and normally wake up. So a lot of what goes on, especially with teenagers, is as you go through adolescence, you become a night owl. They don't have a choice about that. The reason they text at night and everything is because their brain is alert at night. So I will have teenagers or people who are having issues like this take this 2 weeks off, like in the summer. And what you'll find is, I go to bed at 2 o'clock, I sleep till noon, and I feel great.
And that's why there's been so many discussions about shifting the time that high school students go to school.
But I do the same thing with adults too, if it's at all possible to do this, because what you will find is that there are social constraints and other constraints that get your mind going. But once you find out where your real circadian paths are, then we start getting into not sleeping pills. It's really weird that sleep doctors, I think, probably use fewer sleeping pills than any other profession. It really gets more into cognitive behavioral therapy. Once you've got that sleep-wake set, the timing set properly. But if you go to bed an hour or two before your biological clock is going to turn off, I guarantee your mind is going to race. Mm-hmm. That's the thing. And if you go to bed after it turns off, typically, unless there are anxiety issues, an hour before bedtime, calming the day down, turning the lights down at night when you want to go to sleep, turning off the iPads, computers, interesting books, lights. We'll often have patients just sit out in the front porch in the evening for an hour. So you get a habit that you're disengaging yourself from the day so that your brain can recuperate. And then tomorrow, when it's daylight, that's when we deal with our problems. Shopping lists and
all those things we do, in our head. Oh, wait, we've got plenty of phone calls and questions coming in via email. Let's take another email. It's from Ann. She says, I've had chronic insomnia for about 2 years. I've cut out caffeine, alcohol, technology, and kept a strict bedtime, get-up routine. I believe it is more related to menopause. What is the latest research on this? Ann.
I would say, Ann, you're probably correct. There are surprisingly very few studies that look at menopause and sleep. We know that women are more affected by insomnia in general, and that as we age, women, that goes up, that prevalence goes up. If you're having hot flashes at night, you're having hormone imbalances, of course, that's going to disrupt your sleep. And so there's no good answer for this. Unfortunately, even a perfect sleeper, as we progress throughout life, our sleep is going to start to deteriorate. That's one of the joys that we all have to look forward to. But, I think she's doing all the right things, and she just has to keep with it and just realize that the sleep of the past that maybe she had 20 years ago may not be what she can achieve in the future, but she can definitely improve her sleep.
Mm-hmm. What about the bedroom itself? Can you keep it cooler in the bedroom? Does that help us sleep better?
It does.
You mentioned the hot flashes, and that can be really disruptive.
Absolutely. They say that around 65 degrees is the optimal temperature to sleep, which is quite cool. And so, I'll have people, go into their bedroom, kind of, to go off of what you said, you can be sleepy outside your bedroom, you walk into your bedroom, and all of a sudden you're like, oh, what do I need to do? And so, yeah, just taking a look at, do you have TV in your bedroom? Are you reading in your bed? People have a menagerie of animals in bed with them at night. And so all of these things, need to be eliminated from your bedroom so that when you go into your bedroom at night, it's just for sleep.
All right, good advice.
Yeah.
The other thing that I would add, though, I'm going to presume that Ann does not snore. It just strikes me how we don't ask women about apnea, but they can also have it. And premenopausally, men have apnea 2-to-1 to 3-to-1 over women. It's not 10-to-1 like you hear. Postmenopausally, it's about 1-to-1. So you want to just sort of ask.
So she's in that, would fall into that group then?
Although, more likely than not, this really is the perimenopausal, which is not easy to deal with.
Yeah, no, it's
and
not.
And if I can add, moisture wicking pajamas. I'm either a freezer or a heater.
They do make some sheets that do moisture wicking as well.
Yeah. World of difference.
Yeah, I've tried them. They work. Leslie here in Spokane. Leslie, thank you for waiting.
Oh, no problem. I'm learning a great deal, and thank you for having the show.
Very good.
My question, I've been an insomniac for 30 years. I've had 3 sleep studies, and the latest one was through Holy Family, and it was very wonderful. The recommendation of my the physician that sent me to the sleep study was, of course, the CPAP machine. Based on my results, he said after 50,000 patients, you're the worst I've ever had. Anyway, I have tried the CPAP machine on several occasions, and I find I have problems with feeling claustrophobic. And I was wondering if there was anything I could do to override that or approach it mindfully, maybe through some of that cognitive behavioral therapy. So I'd like to know what you advise.
Well, that's a very good question. Thank you for calling tonight.
Well, I mean, that's very common, and compliance is really, really important with CPAP. One of the things that we would always tell patients that came in that had issues is talk to your home health care provider, the one that's giving you. There's a lot of different masks out there, and they're usually wonderful to work with and can, help fit you appropriately to find something that works for you. You can also do desensitization training during the day. So even just try, not when you're sleeping per se, but just try and wear your mask at other times of the day to see if you can reduce that anxiety or claustrophobia that you do feel. But what do you guys
That's what
think?
we do.
Yeah.
What I tell patients is when you get your CPAP, we do it a little differently. We'll prescribe CPAP, then our head tech sees the patient back within a day.
Mm-hmm. Oh, wow.
And we have them demonstrate that they can put it on. We'll have them lie down in a bed in the daytime and put the mask on and go through a desensitization and have them breathe with it. It's your friend. Make sure it's adjusted properly.
Mm-hmm.
I'll often have patients watch a television show, like if she's watching this right now, put your CPAP machine on while you're watching it. And we do just a little bit at a time on a regular basis. PAP naps are called. We don't charge for it. We just do them. But there's a lot of research out there, at least 3 or 4 articles, showing that cognitive behavioral therapy for CPAP adherence is very, very effective. So using basically the same mental health techniques that you were talking about, but not just once or twice. Sometimes we have to do it.
Okay. All right. Very good. Another email, this one from Jen. Is there a place for drugs in treating apnea and insomnia? Are there some drugs available for this?
There's lots of drugs for insomnia. And, there's a lot of research out there that has looked at hypnotic medication, which are just medications to put you to sleep, or they'll use older classes of antidepressants that are more sedating. And those can be very helpful.
Are they addictive?
Some can be, yeah. Some definitely can be. You'll build up a tolerance to it, and you have to kind of increase your dose over time. But there again, I think there's definitely a role for medication in insomnia. But, combining that with behavioral therapy can be extremely effective. And research has shown that over time, those individuals that engage in behavior therapy have the best outcomes. So looking at a year 2 years, 3 years out, the people who engage in behavioral therapy will be more satisfied with their sleep than those that just rely on medication.
Okay, very good.
There was a trial in Europe on treating sleep apnea with a variety of decongestants that are not available in the United States, and it showed some effect, but I have not heard anything about that. It was an article published about 5 or 6 years ago.
All right.
But otherwise, medications don't seem to work for sleep apnea.
The best medicine for sleep apnea is air pressure.
Yeah.
To open the
airway.
airway.
Which comes back to the CPAP.
That comes back
to CPAP. Rosie in Post Falls with a question tonight. Hi, Rosie.
Hi, thank you for taking my call.
Absolutely. And you have a question?
I'm so happy that, yes, I do, and I'm so happy that you guys are doing this on TV because I have severe insomnia, and I'm actually on 4 nights of hardly any sleep at all, and I spiral up and down with this, and I'm just actually at my wit's end. Doctors are frustrated on trying to help me. I'm frustrated. I've bounced back between homeopathic to pharmaceuticals, and I actually have a referral to Providence, to where you guys are. So yay, I'm so happy to get there. But any ideas for me? I've listened to all this, and I'm just so happy to hear all this. You just don't know. Any suggestions?
Rosie, how long have you been dealing with this?
It's been severe for, I believe, about 6 years.
Well, we can certainly see that you're, and hear that you're sort of at your wit's end. So she's been referred, and that's probably an excellent place to start.
She's taking the perfect first step, is having a sleep study and finding out if there are any underlying sleep disorders. And
she comes to the clinic for a test, and she has insomnia and isn't sleeping. Can you still determine what issues she may have going on?
Our requirement, at least in my lab, are really minimal. We have to get 6 hours of data collected. In that 6 hours, we need 2 hours of sleep, and that doesn't even have to be consecutive sleep, just cumulative sleep through that 6 hours, just 2 hours of sleep. And we can get enough information to give the doctor a good idea of what kind of, if there's sleep apnea, there'll be enough respiratory events, enough breathing events to tell us.
It would be pretty common if someone's had insomnia for 6 years and has been treated and it's not effective. Pretty much every one of those patients will be brought in, not for a home study, but this is where you want the big study. And part of the reason is there is a bizarre form of insomnia, I don't think that she has it, called paradoxical insomnia, where you actually will get 6 hours of sleep and the patient will say, I only slept for 2. And there's some reasons for that. And again, cognitive behavioral therapy works for that. But in someone with this type of insomnia, it's really sort of, you would like a formal cognitive behavioral therapy, not just, well, try these rules. It's sort of like, let's keep a sleep diary. Let's meet again in a week and we'll go over the sleep diary, and there are various strategies to use. But you used, I don't know if you still do that clinically, but I know you did.
Yeah, I did practice clinically here in town, but I've moved more to research. But there is a real lack of providers of this type of treatment, and that's a huge issue. One of the remedies, I would say, to that is that there's a few online programs that are pretty good, that have been developed by some very reputable sleep experts. And individuals, if you don't have a treatment provider in your area, can go online. I think one is called Sleepio, another one's called Shut-Eye. And it's pretty minimal in terms of payment. And you can do this type of behavioral therapy online, and some even have coaching that you can, kind of engage with someone. And that's another option for people if they don't have a provider in their area.
This is really a huge point, is that the medical profession, the knee-jerk response is, here's a pill, and usually the wrong pill. And that should not be. The knee-jerk response is, let's talk about sleep patterns, about sleep habits, about relaxation, mindfulness. And this hasn't penetrated not just medical schools, but it has not penetrated psychology training programs. So many psychologists are actually not well versed in cognitive behavioral therapy for insomnia. They are cognitive behavioral therapy for depression, anxiety. But there are a number, if you just go online, look for help, there are a number of, if she doesn't have in post-fall, somebody who's...
All right. This is an interesting question from Barry via Facebook tonight. I'm just curious if the panel has any thoughts or suggestions to stop excessive dreaming. Do you get this question very often?
No, but my question would be, why do you want to stop it? Matt?
Maybe they're more nightmares than dreams.
Well, it may be nightmares, but there's a psychologist, a psychology researcher, Matt Walker, out of University of California, Berkeley, who's just written a book called Why We Sleep. You may want to buy this one. And one of Matt's theories on dreaming is that it helps resolve emotional issues, it helps increase creativity, it helps make you see outside the box, so when you're presented with problems and you can't figure them out, you have a nice episode of dream sleep, and the next thing you know, I know what to do. So unless they're nightmares, I'd sort of be joyful.
Interesting. Mike from Cheney with a phone call. Hi, Mike.
Hello.
Thank you for calling.
Thank you for taking my call. I have a friend who has a very strange problem regarding sleep. Her doctor has sent her for several tests, and her doctor doesn't know what else to do. Her problem is bloating and abdominal pain and burping up air at night, about 11 o'clock at night, and this has been going on for about 5 years. And it goes on for about 3 to 4 hours during the night. I was wondering if there could be some reaction to a medication called Lodipine for blood pressure.
Okay. Dr. Simon?
I wouldn't think so. But
have you ever heard of anything like this before?
I have, but not lasting that long. And I mean, the question I would wonder about, if you're bloating and doing this as you're going to sleep, could it be a bizarre sort of seizure disorder, for example, repetitive activities occurring right at sleep onset. I don't know if this person's had a sleep study or not, but the aerophagia, she's not on CPAP. This can be seen in patients on CPAP machines. But just the air swallowing and the bloating, I honestly don't know.
LeAnne, have you ever seen anything like that in the clinic?
Well, the first thing I thought when he was describing his friend's problem was reflux, gastroesophageal reflux. We get patients that have to sleep like on a wedge or with their head elevated to just kind of keep those gastric contents down. And he mentioned the, burping and the. That was my first thought, but it's definitely something that she should see her doctor about and maybe have a sleep study.
All right. Lori here in Spokane with a question. Hi, Lori.
Hello there.
And your question?
Okay, I was diagnosed with narcolepsy and cataplexy back in '99, and I went through treatment with Adderall, Ritalin, Provigil, and then I ran into a doctor that said, "Oh, you're an addict," and I just pretty much thought, "Okay, I'm done," and I dropped off all my meds and went on, assumed life. But I'm wondering, what is new out there for treating narcolepsy?
First of all, Devon, explain what narcolepsy is.
So narcolepsy is a really interesting sleep disorder where essentially individuals have overwhelming, it's kind of like an overwhelming drive for sleep. And so these sleep attacks can occur very unprovoked, usually associated with extreme emotion. Could be anger, could be laughter. And in rare cases, so the cataplexy, and correct me if I'm wrong, is a little bit more rare. So people don't necessarily have, we have this idea of, the falling down to the ground sort of cataplexy, but usually it doesn't have to be as pronounced as that. It could be just, like a head droop or kind of, feeling weak in the knees. So this is, something to do with the receptors in your brain. So there are good treatments for that. One thing I know, and please correct me if I'm wrong, is that some of the treatment has been more focused on getting better consolidated sleep at night and less on this, stimulants throughout the day, because those can be addictive in the sense, and you do build up tolerances and can have long-term kind of cognitive impairments by that. So I would say it's time to see a different sleep doctor who's maybe a little bit more knowledgeable with narcolepsy.
No.
and get a different regimen.
Well, the other thing is, when I give talks to other doctors, narcolepsy is a difficult diagnosis to make. If there is a chemical test that you can do at Stanford in the spinal fluid, which is pretty helpful, but most of us don't have access to that, so we do functional tests. And how the NAP studies are done, how the sleep studies are done, the details are extraordinarily important. So I would say most of the patients I have from the 90s with narcolepsy actually don't have narcolepsy. So I would want to make sure she actually has it. So if you stop all your medications and you really have narcolepsy, you're going to be dysfunctional. You're going to be falling asleep all the time. So the thing in narcolepsy we treat is the sleep consolidation at night, usually something to make you more alert in the daytime, and then the cataplexy, which is the paralysis of dream sleep that occurs when you're emotional in the daytime. We often use antidepressants for it. That's the traditional therapy. But there is a new medication, sodium oxybate, that does just what you talk about. It consolidates sleep more. It has a very narrow therapeutic threshold, though, so it's somewhat of a dangerous drug, regulated by only one pharmacy in the country. But for cataplexy and narcolepsy, it can be extraordinarily effective if used properly. So she just needs, as you pointed out, a reevaluation, I think.
I find this one interesting, and it's from Margaret. It's via email. Are naps good for you? I have an unusual schedule. I find that I take naps now and then, and I've heard some discrepancies about how long I should nap. What do you think? She's the expert.
I'm going to butt in and say naps are always good for you unless you have insomnia. And if you have insomnia, we may change our tune on this. But insomnia patients, we don't want them to nap because we want them to get sleepy in the daytime to drive sleep at night. But for the rest of us, if you're sleepy, naps, and there's two types of naps, in my opinion. They've done all the research, so it's going to be really cool to hear this. But there's the short nap, 10, 15, 20 minutes to improve acute performance. So if I'm going to play before a symphony, I'll take a 10-minute nap the hour before. But then there's the other type of nap where you're trying to repay a sleep debt, like college kids coming home, and that you just sleep as long as you can.
Yeah, I totally agree with that. The only thing I would add is that timing in the day is very important. So you don't want to be trying to take a nap, late afternoon, close to bedtime, and you really want to limit the amount of time that you're trying to nap. So, ideally 20 to 30 minutes is perfect because that allows you to kind of stay in those lighter stages of sleep. If you take longer naps, you're more likely to get in the really deeper stages of sleep, and then you're going to wake up, you're going to feel really groggy, and then it just kind of takes away from what you're building up to achieve at night.
So keep it nice and short.
Well, researchers at Harvard and also at Cal Berkeley and other places have shown that if you come in well rested to school, you'll learn more. Take a nap right afterwards, it'll consolidate the learning even more. And then take 2 or 3 good nights of sleep even after that to continue to consolidate the learning you got 3 days ago.
Sala in Cranbrook. Hi, Sala.
Hi, thank you for taking my call.
Absolutely.
Yeah. So my question is, I'm 72 years old and have heart problems for many, many years, since I was 13 years old. And I had developed arrhythmia. And then with medication, for years I took medication to solve the arrhythmia, but it didn't. And then eventually my mitral valve was leaking, and I had to be replaced. So since then, I've been I can't sleep. So they gave me so doctors prescribed so many different types of sleeping pills. Some of them, they were very, very, very strong, and I couldn't function during the day. And then the last 4 or 5 years, they put me on lorazepam, 1 milligram a night, and I fall asleep. In 15 minutes, I fall asleep, but I wake after 4 hours or so. I wake up.
All right. Any advice for Sala?
Well, it gets back to if you've got heart disease, you want to make sure that there's not significant apnea. I mean, I hate to say that, but we do need to know that, because sleep apnea and heart disease, although this sounds like more valvular heart disease, are so integrally tied with each other. So I'd want to know that. And I would want to know the sleep-wake schedule. And again, this would be a person that if there is no apnea, there's no restless legs, the heart disease is going well, look at medications. We're talking about cognitive behavioral approach rather than medications. Lorazepam lasts longer than 4 hours. So my bet is it's not doing a whole bunch.
Okay. I want to try and get in another email. Does alcohol affect sleep? And that's coming from Maxwell.
Yes.
In what way?
Well, it's fantastic to put you to sleep, but as our body metabolizes it, it actually fragments our sleep and wakes us up. So for insomnia patients, what I would recommend is that, you're going to have a glass of wine with dinner, great. That's no problem. But, this idea that, well, I'm just going to try, to maybe drink enough to get myself to be sleepy, that's going to, again, put you to sleep, but it's actually going to end up ruining your sleep later on. So yes, there's a huge impact of alcohol on sleep.
Okay. We're getting close to the end of our hour here already. So I want to get just a quick final thought from each of you. Advice for our viewers. We have a lot of interest in getting better sleep. And what are some final thoughts that you would leave our viewers tonight with? And LeAnne, I'll start with you.
Well, I think the most important thing for anyone's sleep is consistency. Go to sleep at the same time at night. Get up at the same time in the morning. If you nap, great. Nap every day, nap consistently, sleep consistently. There's so many people that, sometimes I go to bed at 2 a.m. and sometimes I go to bed at 9. And you're just borrowing from, what is it they say? Borrowing from Peter to pay Paul.
Yeah. Find your pattern and stick to it.
Find your pattern and stick to it.
Devon?
Yeah, I would say, again, 7 to 8 hours in a 24-hour period is really the goal. If you can't get a consolidated period of sleep, trying to break that up and getting, maybe a couple naps can also be effective. But I think consistency is possible, or is also really important. It's kind of like diet and exercise. If you struggle with sleep, you may always have to work a little bit harder to achieve good sleep.
All right. And very quickly, Dr. Simon.
Sleep should be quiet.
That's brilliant. That's a wonderful place to leave it. Thank you all so much for being here. It was a wonderful discussion, and we apologize if we weren't able to get to your questions tonight. Thanks to our panel. Our thanks as well to everyone who called in and emailed a question. And we will be back next month with another edition of Health Matters. Join us November 16th when our topic will be end-of-life care. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?